which has been organizing parent talks for the last 10 years. So I think Mark was there this year, and he invited my colleague Brian Kushner initially, who couldn't make it, and so I decided to come and share our data with you. As a clinician, I have to thank families and patients with neuroblastoma to keep on inspiring us, and we feel a lot of pressure seeing a lot of patients with neuroblastoma to keep on doing better. So that's how we stay on our toes and keep thinking of new therapies. So I have a big, long task, and after hearing some of the questions and comments this morning, I've kind of changed my talk a little to give you a big overview of what's happening at Memorial Sloan Kettering. And also fear that I'm not going to alleviate any of the confusion that exists. So you'll have to bear with me, and if there are any questions, I'll be happy to take them, but I'm going to outline a series of clinical trials that we are performing, and the question is how to choose between them is still a difficult one. So I've put a couple of slides in as to how we choose between all the studies, because we have about 25 open studies at Memorial for patients with neuroblastoma, and I've put in a couple of slides to try to tease out how to choose one of these studies. I have my email there, so if you need to reach out to me, please feel free to email me. So the main themes which I want to talk today is that we try to reduce therapy where feasible. And over the last couple of decades, there's been a paradigm shift in that patients with relapse can actually be salvaged. And you've seen some of that data from Dr. Hangrattinger, if you can achieve second remission. We are very big with doing surveillance scans, and that kind of ties up with the second point, the idea being that if you can pick up recurrence early, the outcome is going to be more successful. And we've been focusing on tailoring therapy to the patient and are more patient-focused rather than protocol-focused. So this diagram I'll be coming to again, and this outlines in general the management of patients with neuroblastoma at Sloan Kettering. And patients with stage 1, 2, 3, and stage 4S disease who do not have MYC and amplified tumors, we've been treating with surgery alone. I'm not going to dwell too much upon that group. Similarly, infants less than 18 months of age at diagnosis have a very, very good outcome with standard treatment, with more than 85% cure rates. For some reason, this numbers have disappeared off the slide, but our outcome for this group of patients here has been 90% or more without any treatment whatsoever. And the overall survival for patients with high-risk disease without transplant, as many of you know, we have not been doing autologous transplant for the last 17 years or so, has been improving over the years. So a couple of slides about low-risk disease. So as I mentioned, low-risk disease or locoregional disease can be treated with surgery alone as long as tumors do not have MYC and amplification. Because we always ask ourselves first whether, not how do we treat, but whether we should treat. Because as you all know, the consequences of treatment, including secondary cancers, growth failure, etc., can be significant. So for example, a patient with a very large stage 3 tumor without MYC and amplification can be treated with surgery alone, and we recently published our data even for stage 3 patients. We've not treated them with any chemotherapy whatsoever. Nor do we conduct Herculean surgery to remove all the tumor, and many of these patients do not undergo complete resections and still have a very favorable outcome. Similarly, for MYC and amplified, non-MYC and amplified stage 4 in an infant, we try to reduce chemotherapy as much as we can, and sometimes patients continue to have MIBG therapy. For example, this is a patient who is now 3 years out of treatment, whom we were unsuccessful in clearing the bone marrow and the bones, with low-dose chemotherapy, but we have not subjected this patient to high-dose chemotherapy, and she's doing very well. So the bottom line is that infants with stage 4 neuroblastoma without MECAN amplification can do well even with persistent MIBG disease. The group of patients I'm going to talk about today, which is of interest to everyone here, are the high-risk patients, and especially those who have progression or relapse or who are refractory to chemotherapy. So for the first group of patients who we treat with induction chemotherapy, which is 5 cycles of high-dose chemotherapy, surgery after 3 cycles, and radiation to the site of the primary tumor, about 80% of these patients will achieve remission after induction chemotherapy and surgery. And these patients are what we call complete remission or very good partial remission. These patients we treat with antibody 3F8 plus GM-CSF and cisretinoic acid. About 20 to 25% of patients will not clear the disease. These patients we term as primary refractory. I'm going to talk about how we deal with this group of patients later. And a very small group of patients have actually progression on chemotherapy, and some patients don't completely get rid of their disease after second-line induction chemotherapy, and I'll be focusing a lot of my talk on this group of patients. As far as the upfront treatment is concerned, there are some kind of salient points I wanted to point out. One is that we've been reducing the number of cycles over the decades. At one point we had 7 cycles of chemotherapy, and now we have 5 cycles. There's possibly less ototoxicity, although this is not an evidence-based statement, but definitely the risk of secondary leukemia has fallen to the point that we have not seen any patients develop secondary leukemia after getting 5 cycles of induction chemotherapy. Surgery to remove the primary tumor is an extremely important part of the treatment, and Dr. Lakhwalia as surgeon adopts a thoracoabdominal approach which allows the disease to be visible and also lessens the risk of renal loss. Our patients get hypofractionated treatment twice a day. Whether this is important in the clinic or not, we are unsure, but there are some data in the lab which indicate that hypofractionated radiation, which we provide using intensity modulated radiation techniques, is less toxic. But that data again is not in the clinic. And we do not use IL-2 with our immunotherapy. As we all know, the toxicities of IL-2 are significant. So Mai Kong Chung, my boss in the 1980s, developed an antibody called 3F8, which recruits NK cells, neutrophils, and macrophages, as well as deposits complement, all of which leads to neuroblastoma cell killing. We have been treating patients in the clinic for the last 20 years or so. There is intense pain, but it's short lasting. Our infusion time is only 30 minutes. We have not seen any long-term toxicity, and in a series of published publications, we've shown that 3F8 plus GM-CSF is of clinical benefit to consolidate remission, and also shows a very high response rate in patients who have bone marrow low burden disease who have not responded to chemotherapy. So I'm not going to dwell on this information, but our overall survival over the decades has significantly improved. Now again, this is the caveat here is not that this is event-free survival. This is overall survival. So I want to point out that the x-axis here is in years. So we are dealing with 5, 10, 15, 20, etc. years of follow-up. So say if you look at the 5-year follow-up in patients who receive 3F8 plus subcutaneous GM-CSF, their overall survival is about 70%. That doesn't mean that they have not recurred, but despite having recurred, they continue to be alive and relatively well, often with some sort of therapy needed intermittently, but their overall survival is pretty good. And the reason for that is, and I'm going to come to that, is perhaps because of our surveillance scan philosophy, we've been able to pick up relapses earlier and earlier. Now, how do we deal with patients, the 25% of patients who don't respond to first-line treatment? So our philosophy for this group of patients is to try and get them into remission somehow. And somehow is using second-line therapies I'm going to talk about. And if patients can achieve a remission with second-line therapies or their disease burden can be reduced significantly, we treat them with 3F8 and GM-CSF. So what are the second-line therapies? We've conducted a large number of studies in a significant number of patients using all these combinations. So there's hydrocyclophosphamide, topotecan, irinotecan, carboplatin, irinotecan, temozolomide, ifosfamide, carboplatin, etoposide. Now, none of these is a home run, but I would say in about 20% of patients who don't respond to first-line treatment can then achieve a full-fledged remission with one of these second-line therapies. So going back to the previous slide, at this point, we would, instead of putting patients onto a study, we would try to achieve a remission using standard therapies rather than saying that these patients are completely not sensitive to chemotherapy. Now, this doesn't succeed in all patients. So in those patients who we do not succeed, again, we try to use, before putting them onto a full-fledged study, try to treat patients with irinotecan, temozolomide plus Avastin, which is going to be one of the arms of the Beacon study, as I hear, or with MIBG therapy, often followed by some sort of chemotherapy, or we use haploidentical NK cells. And this is a strategy which is different from what Dr. Hang-Grettinger reported on, in the sense that this is not in the setting of an allotransplant. We just take NK cells from parents and infuse them, and because we are depleting all the T cells from the parents' collection, the GVH does not occur. So in those patients who do not respond to this second-line treatment, we try to achieve remission again with this type of approaches. And if patients are left with bone marrow disease alone, 3F8 plus GM-CSF itself can clear bone marrow disease. Now, this is a small group of patients who do not have any MIBG avid disease, but have bone marrow disease alone. And the key message from all of this is that even those patients who have not completely cleared their disease with upfront and second-line therapies can still be curable. The main problem we face, as you heard, is relapse. Even after disease has been completely cleared, about 40% of our patients relapse. And again, the key message is that relapse is curable. So we have not ever worked with the philosophy that relapse patients are incurable. And one of the reasons why our patients, why we say that is because surveillance scans may help in this situation. For example, a relapse could be a very focal relapse. For example, this patient had a relapse in the cranium and a small relapse in the fibula. And this patient, we could easily achieve a second remission and then try to consolidate second remission using several studies which I'm going to talk about. Another example is a patient who had a relapse in the adrenal bed but did not have any distant relapse. So this patient then underwent a second surgery and then remained in remission for several years. So surveillance scans can detect single focal relapses which can be more amenable to therapy. And over the last decade or so, we don't see that many patients with disseminated relapse, that is relapse in soft tissue as well as multifocal relapses in skeletal areas, except for those patients who relapse early having had a MEK amplified tumor. And we can talk about that if the question arises. And the third reason is about 8 to 10% of patients relapse in the CNS without relapsing anywhere else. And detection of an asymptomatic relapse in this patient can really make a huge difference to the patient's life, as well as the neurological deficits which these patients can experience. So we have been doing MRI scans of the head as part of the surveillance panel. So having said that, if a patient relapses, we don't think that one size is going to fit all relapses. So each relapse is treated as an individual patient, and therapy has to be targeted to the type of relapse. For example, if there's a focal relapse, a focal soft tissue relapse can be removed. A focal skeletal relapse could be radiated and given some low-dose chemotherapy, and then we try to maintain a remission. So the type of therapies for patients who recur are not standard. One place where we've had a lot of success is in patients who relapse, have an isolated relapse in the CNS. And these patients undergo surgery to remove the CNS recurrence, chemotherapy with irinotecan, craniospinal radiation with a boost to the site of recurrence, and then radioimmunotherapy with intra-Ommaya 3F8 or 8H9, followed by further systemic consolidation with 3F8 and GM-CSF and Accutane, and then ongoing chemotherapy with oral temozolomide for 5 cycles. So using this kind of serendipitous regimen, which is not a formal protocol, we have been able to salvage most of our patients with CNS recurrence, including those patients who have significantly large hemorrhagic lesions. In fact, this was the first patient we treated who is now 8 years out of CNS recurrence, and he's a linebacker on his football team. And over the years, this favorable outcome has remained positive. So this is an old slide where we had 26 patients who were treated on this regimen. This is now close to about 35. Again, we have to remember that this recurrence is relatively rare. The incidence of CNS recurrence is only about 8% of patients. And in the UK, there would be only 1 or 2 patients diagnosed with CNS recurrence every year. So we have to keep that in perspective, that this recurrence is rare, but the bottom line is that these patients can have a very favorable outcome. So when we compared this to what we had done in the pre-1990s, where all patients died of their CNS recurrence, we seem to be having a lot of success. Now, for patients other than CNS disease, how do we deal with that scenario? We first, if there's a recurrence, we first do some reinduction treatment, and our goal is to achieve a second complete remission. If we achieve a second complete remission, we consolidate that remission with either with humanized 3F8 in this day and age, or with the bivalent vaccine. And this is the only study I'm going to talk about in some detail, because this is the one study which is probably going to open up in the UK. As to how far it is in its development, I cannot tell you, but I'm happy to take questions about this down the line. If we don't achieve a complete remission, but we are successful in reducing disease burden, then we put patients onto phase 1 and phase 2 studies. So the next 4 slides are a listing of all the phase 1 and phase 2 studies that are available. But I did want to put this in perspective, that we don't automatically put any relapse patients onto a study, but we tailor the salvage therapy based on the type of relapse, as to when the patients have relapsed, etc. So patients can undergo, the open studies at this point in time are combinations of cyclophosphamide, topotecan, and bevacizumab, irinotecan, temozolomide, bevacizumab. This study is almost complete now. Vorinostat, which is an HDAC inhibitor, and etoposide. My own interest is in radioimmunotherapy, the targeting of tumor with radioisotopes. We've completed a study of targeted radiation with an anti-angiogenic agent in patients with neuroblastoma. My colleague Kim Kramer is supervising the studies of intra-Ommaya 8H9 and 3F8 for brain mets. We have an open study using MIBG therapy. We're just about to open a study which is looking at labeling humanized 3F8 with a PET emitting isotope to get a better picture of how antibodies behave when they're injected into patients. We're developing a new agent called MFBG, where instead of iodine, this will be a fluorine molecule. So since fluorine is a PET emitter, there is the potential to get much better images using this agent, and that should be opening next year. And in mouse models and primate models, we studied these two agents, some of which Dr. Hangrettinger referred to. We have an actinium-labeled 3F8, which is an alpha-emitting isotope, and then zirconium-labeled humanized 3F8. I'm not going to talk about these today. We have, as Giuseppe mentioned, there has been better interactions with pharma over the last 3 or 4 years. So we have been part of an international study, which is also open here, using a new ALK inhibitor, and a new study using an agent called LEE, which is a CDK4 and CDK6 inhibitor. Our local small molecule uses periphospine, which is an AKT inhibitor, and then a couple of studies in development is an HSP90 inhibitor and a novel molecule called an epothelone. As many of you know, we have now humanized 3F8. So we have 3 humanized 3F8 studies, all of which are targeted for minimal disease. That's humanized 3F8 alone, humanized 3F8 plus recombinant IL-2 used in a regimen similar to that used by Dr. Leidenstein's group. 3F8 plus GM-CSF, a bivalent vaccine. I mentioned the haploidentical NK cells, and we have now developed a BiTE, or a bispecific antibody, which targets T cells as well as NK cells and neutrophils and macrophages, and that study should open up next year. Another kind of newer approach to patients with recurrent disease is that we've been trying to test all patients who relapse, subject them to genomic sequencing. And the genomic sequencing for these patients is being done by a private company, which is in this case called Foundation One, although there are other companies also in the US. But the main advantage of this approach is that this is an FDA-approved CLIA certified test, which means that any data that comes out of this test can be used to make clinical decisions. So as you heard from Giuseppe, there are more and more targets being discovered. And I've just put here 4 anecdotes on patient samples which I've sent. We all know that, we know that patients at relapse really don't have many genomic abnormalities in the primary tumor. So we know that some patients have MECAN amplification, other patients have ALK abnormalities. But other than that, if you study the genome in patients who have neuroblastoma at diagnosis, there are almost no other targets to be found. So to hope that that sort of approach is going to work for at diagnosis, I think is a little premature. Having said that, since we've now been testing all our relapse samples, we've been finding an increasing number of genomic abnormalities. For example, in one patient recently, we found an NRAS mutation, and we know there's an FDA-approved drug for NRAS called trametinib, so I've started this patient on trametinib. Another patient showed abnormalities in the mTOR pathway. There's a drug that exists, so we're going to start this. We've started this patient on an mTOR inhibitor. CDK4 and 6 abnormalities. There's a new drug which is going to be available very soon. So this type of approach may help you decide whether personalized medicine can be applied based on genomic testing. Now, we don't know yet whether this approach is going to be successful, but at least if you have a bunch of studies to choose from, this is one way you could go about using a more specific drug. So I wanted to talk about the vaccine. Vaccine is, we know that neuroblastoma itself is not very immunogenic. That means our bodies don't mount a very good immune response to neuroblastoma. And GD2, a favorite target for many immunotherapists, if you take GD2 and inject patients with GD2, our body does not make any immune response to GD2 because it's a glycolipid. It's a sugar and a lipid molecule, and typically our body is not geared towards making an immune response to a glycolipid. So our theory was that if we made the glycolipid more immunogenic, either by attaching it to a protein called KLH, which is made from shellfish, and another agent, OP821, which is made from tree barks, and treat patients with other immunostimulants, we could make GD2 immunogenic. So that's the idea of the vaccine. So we take this whole concoction, we inject it into patients, and the group of patients we chose was a group of patients who did not have any evaluable disease after relapsing. So we got patients relapsed, we treated them with chemotherapy or other agents, we got them into remission, and those are that group of patients, which is a group of patients which is traditionally considered at a very high risk of recurrence, were treated with this vaccine. We did find that there were immune responses in our patients, and this vaccine is given as follows, spread over 1 year. We have not seen any pain or dose-limiting toxicity. Whether that's good or bad, I don't know, but that's our observation. And there's no real significant toxicity we've seen, but a lot of these patients seem to be doing well. And in this old slide, which went on to 2 years, we've had many more patients now treated with this vaccine, and the data may not be as robust, but it's still in this ballpark. So for some reason, these patients seem to be doing well, but again, this has to be taken with a pinch of salt, because we may have chosen patients who are already cured with second-line treatments, although that's not typically what you would expect. But these patients seem to be doing quite well, and maybe 2 years down the line, if this data holds up, we'll probably be more excited about this. The reason I bring this up is because recently there was one of the UK charities funded a study, a multi-center study, which one of the investigators in Bristol, and trying to bring the vaccine to the UK. I don't have any more information as to where that is exactly in development yet. Last point I wanted to talk about was 3F8, humanizing 3F8. Why humanize it? Because mouse 3F8 gives rise to an anti-mouse antibody in most patients. The humanized 3F8 which we've produced has better cytotoxic qualities. And comparing it to some other antibodies, we see that humanized 3F8 has a higher ADCC. Another important point in the development of 3F8 was the way it was developed. This was a completely parent-funded drug. That is, right from the development of the drug to its production to the clinical trials was completely funded by the Band of Parents, which is an umbrella group of organizations in the US, which has created a unique kind of funding mechanism. So they raised about $2 million, and that allowed us to be independent of Pharma. So this drug is completely Pharma independent, because Pharma really, even though Pharma is collaborating more with us, the drugs they're interested in are drugs which are available for adults and primarily are for adult therapies. No Pharma is developing a drug for a pediatric indication. The two exceptions, one is the CH1418, and the other exception is clofarabine, which was a drug which was made for childhood leukemia. Other than that, there have been no drugs created by Pharma for pediatric indications. So whatever we talk about better Pharma relationships, those are for adult drugs which are used for treatment of adult tumors. So we need to kind of keep that in perspective. So with this kind of novel funding mechanism, we were able to make enough 3F8 at a fraction of what it would cost Pharma, because there are no marketing costs. And the $2 million is going to be enough to run both the phase 1 and phase 2 studies, including several spin-off studies that we're planning. So this has been an exciting time for us. We've been able to use a very complicated process, which I'm not going into, to create a drug in a relatively short period of time. From the first experiment to the first study took only about 3 years. We feel that this is important because it's going to create a platform for further immunotherapy studies. We are about to write a new study using haploidentical cells plus humanized 3F8. We can create humanized 3F8 variants with better properties. We've used this platform to make BiTE cells, which Dr. John talked about. We're looking at conjugating novel isotopes to the humanized 3F8. And this is just an example of how 3F8 has recruited NK cells, neutrophils, macrophages, but this T cell, which are very potent T cells, which 3F8 was never able to recruit, can now be recruited using a bispecific antibody, and that trial is hopefully will be launched late next year. Besides GD2, there are a couple of other targets we're interested in, which I'm going to skim over. This slide kind of collates all the therapeutic trials that are open for immunotherapy. Here's a BiTE. Here is an example of a chimeric antigen receptor, which John Anderson's working on and the Texas Children's Group is working on. So I think there are pros and cons of all these studies being done in a single center. The type of patients we see are patients who have problems. That is not, most of our practice is patients who cannot get standard treatment or have relapsed or have resistant disease. Some families come to us because we don't do transplants, and other families come to us because of problems with IL-2 related complications. So we do see the more difficult type of patients. The exciting part of working in a place like Memorial is that there's a very rapid turnaround. So unlike what I hear with multi-institution studies, because we are a single institution, there's a much more focused group of people. Because we have a large number of studies, we can afford to kind of choose which studies to choose for our patients. There's a very, very large number of people who are focused on treating this one rare disease. But there are also disadvantages. Single institution data always appears to be better. So when we look at the same data, for example, induction chemotherapy, our induction rates are close to 75%, whereas the same chemotherapy used by the French group reported on rates of 55%. So there are problems in single institution versus multi-institution studies. We have to create therapies which can be translated and portable to other institutions, and that's a challenge as well. And the data which we generate as a single institution have to be validated in multi-institution studies. So we see ourselves as a more of a pilot type of an institution which conducts pilot studies. The successful studies should then be translated and validated in multiple centers. So the take-home message is that we hope to cure patients with less toxicity and fewer long-term side effects. I'm convinced that there's been a paradigm shift in patients who've relapsed. Historically, relapse was equal to death, dying from disease, but I don't think that's true anymore. Patients who recur in the brain, we've stumbled upon some effective salvage therapy from them. We feel that comprehensive surveillance is very useful to detect early relapses. I didn't mention this much, but we do insist that many stem cell aliquots should be stored because there will be an increasing use for these aliquots for relapse. And we are focused as a group on creating novel therapies with limited toxicity. And there are a very large number of people who allow this to happen. Not only physicians, but also families, federal agencies, and a large group of other people. So if that's all I have to say, If I have any questions, I'll be happy to take those.